something may happen to 2021. And today we're going to see this one we termed a bat in the vent, and it will make more sense in a second. You probably can realize that with my inability to pronounce the B and the V, they both sound the same. A bat in the bat. All right. So disclosures. The first ones we discussed particulars of ventilator modes. There's no endorsement whatsoever of any mode, manufacturer, or company. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic opinion. I'm Eduardo Mireles. I received some royalties from books, chapters, and some lectures, and co-owner of a patent with Rob Chatburn that you see here. And Rob, these are his disclosures for you to be aware of. Ground rules, this is a recorded session, so keep your microphone muted unless you want your dog to be recorded for posterity. The moderator may call upon members of the audience to comment. If you have any comments that you want to do or questions, just put them on the chat. If we want you to elaborate more, we will ask you to unmute and go from there. Today, we're going to be using the web poll to elicit the audience interaction. And again, as in others, the Cleveland Clinic employees will get CME. There's a QR code at the end of the session. This is all recorded and in YouTube posted the next day for all of you to review and come back to us. So we're going to start with this one. You can immediately see the bat in the vent. And I'm going to activate the poll for all of you. And as you're reading this one, I will ask for one of our fellows to voluntarize themselves to this. So here goes the poll. And again, this is anonymous. I cannot see who's answering what. Just fill it up. What's the mode? What is the load? And then what's the patient ventilator interaction? And I'll give you a couple of minutes to fulfill this as you look at the bat in the vent. For those of you joining, the poll is open. You can answer, fill it up. Have no fear, it's anonymous. Erin, I'm going to decline you annotating because if not, it appears on our screen. It's not lack of love.
I hit the wrong button. I was trying to hit the poll button.
I know that's number one. It always happens. Very good. I'm going to give you another 30 seconds. Twenty seconds to close. Do we have any volunteer that wants to read this waveform, the Batman waveform? From our fellows, have no fear.
Dr. Mireles, I can try. It's not going to go well, but I can definitely try.
Marina, I appreciate that. I applaud it, and I know that you're going to do great. So let's take a look at do you want to see the poll results before or after?
Let's do it after so that I don't chicken out.
There you go.
Okay, so starting with the tag. We know that ventilators are really good at controlling volume and flow, but not so good at controlling pressure. And what I'm seeing is a really messy pressure and a really messy volume waveform. So I'm going to go with volume control. Sorry, not volume control, pressure control. I'm so sorry. pressure control.
Okay.
And the machine is triggering every breath here. So I'm going to go with CMV. I am going to go with for the load. So I'm seeing a lot of PMUS in the inspiratory phase. And the expiratory phase, I can convince myself is probably elastic and not resistive because it's not prolonged. And here is where things get a little bit tricky. So what I'm seeing with the trigger, I am seeing a, goodness gracious. I'm seeing the machine trigger, and then I'm seeing the patient. No. Okay, so I'm seeing the patient pull in at the end of expiration and then the machine trigger after that. So that would be late because the machine is going after the patient.
So the trigger, just let's so trigger is this phase, right, Marina?
Yes.
So does the color change? What does this color change mean?
The oh my god, the machine, the patient triggering.
Yes.
Yeah.
So the patient is triggering, right?
Yes.
Okay.
So the patient is triggering everything. So sorry, I don't know where my head has gone. The patient triggering everything. So the trigger is normal.
Okay.
You see some work shifting with inspiration.
Mm-hmm.
The machine stops the breath. I'm going to go with normal cycle and a little bit of work shifting and expiration. The thing that I'm noticing on the waveform at the bottom is there looks like there's a leak in the first two breaths. And so I'm not sure how that's contributing to the way that the breath cycles off, and would be kind of interested in hearing what you have to say there, Dr. Mireles.
All right. Very good, Marina. So let's continue this. I think that you are completely right, PC, because the ventilator is very good at controlling flow, and you don't see any geometric shape here, and it doesn't start like if it was a descending ramp or a square waveform. So it's definitely pressure control. I agree with you. The next one is CMB, and all the breaths are triggered by the patient. So what you have here left to come to is this actually triggered? Oh, let me see what the polling showed. Let me show the polls, poll results apply. So let's see what the people said, and then we'll finalize that. So for what the groups, the majority of the group felt that this was pressure control CMBS. So they were with what you thought. The majority thought, actually all of them thought that it was PMOS, that what we saw during the main load, which is what you said, Marina. Then the trigger, they felt it was normal. Majority of the group felt that it was normal. There were some that thought that there was some late and maybe some failed trigger, or yeah. Inspiration, the majority thought that there was work shifting. A couple thought that there was severe work shifting, but the majority felt this was just work shifting. In terms of cycle, the majority was with you in that this was a normal, although there were a couple that thought that this may be early or late. And finally, in terms of expiration, the majority thought that there was expiratory work. So pretty aligned with what you said, Marina. All right. So let's just finish the tag. So CMB. So how do we know this is CMB? And it's a little bit tricky because you see it cross through immediately, and there is no evidence of pause except right here. This is the only one that gives you the clue of what's actually happening, of what's that this is a mandatory breath. You see that little pause right there? That means that the eye time of the patient, the neural time of the patient was shorter than the patient. And so this is a little late cycle, which tells you that the breath, the respiratory
Our
therapy,
cycle kind of machine.
yeah, they did a great job on synchronizing the eye time. But in this one, the patient just went a little bit faster than them. So this is CMB, absolutely. And the targeting scheme, it's hard to say. In this sequence, the pressure remains the same, and I would say that the real pressure that the patient is experiencing is around here. It's around that little chink that it has, and so this is CMBS until proven otherwise. Then
Dr.
you have,
Mireles, would it
yes,
be appropriate at all to call this IMV? Like what the first two breaths, is there a chance that those are that we can just call those patient triggered, patient cycled?
it could be. It could be. It would be hard. Just I know what mode it was. I just cut it off, but it
Yeah.
was somebody had set the eye time very well, so you could absolutely say. But if you notice, this one is shorter than these ones, and so under the circumstances, if it had been longer than the other ones, you could potentially say it the other way around. So the key here is that this one is shorter, so it tells you that this was probably a really good respiratory therapist putting the eye time to match what the patient wanted.
Gotcha.
So good point. Thank you, Marina, for bringing that up. Let's go to the load. Absolutely PMOS. It's all that you see here is PMOS. The patient, this instead of having that beautiful decay that you should have, that should look like that, all of this is PMOS. The patient got pressurized and then he gets a lot of effort. And then when the patient is exhaling, it doesn't decay as it should. It doesn't decay nicely like that. And that makes me think that the patient is doing effort also during exhalation. This tries to approach towards baseline, but I think it's just the patient is kind of stopping the expiratory effort a little bit, it's kind of getting to the end of it. And that's why you don't, that may look like a missed or failed trigger. But I think that in general, these are just normal triggered breaths, one after the other. And so this is PMOS over here. That's my feeling. Trigger, although the trigger drops a significant amount, it's actually pressurizing pretty fast. The patient, you can see how rapidly it's going up. So I think that I'm 100% with you that this is normal. And I don't think that this is a failed trigger, but I mean, you cannot tell without an esophageal balloon, but that would be suspicious, but not completely. I think it's just the expiratory muscles are relaxing at the end. Work shifting, we said that, and I agree with you completely. And then there's the cycle, which I think that in majority is normal. It's just this one that it's a little bit late that gave you the hint. And then there's the expiratory work. So the question, Marina, to you and to the audience, I want to see if people want to put it on their high quality chat, is what is this? I get this pen. What is this and what is this? What is the Batman ears? Why do we have ears there? Because that distracts me enormously when I see this, right? You look at the waveform and you're trying to go through it and you're looking at these darn bat ears in each one of them. So what are there? Anybody? Marina? Should I worry about them?
I'm seeing a lot of answers that say overshoot in the chat, but I have, I'm going to admit that I have no idea.
So I see overshoot, time stamping. I know. Second one could be rapid muscle relaxation, overshoot and active exhalation. Yeah. So this is a common thing that you will see when you pressurize the system. Actually, you see the flow goes really high, really fast, really up, and as it pressurizes the system, the flow goes rapidly up, but the machine is trying to keep the pressure at a certain level. And that's so it sees that it overshoots the pressure and it comes rapidly down. Now, if you so this is an artifact. This one over here, it's a complete artifact. And it's if you remember our lectures on what is the load at the beginning of the breath, just at the beginning, when the flow is the highest, the majority of the load is resistive. There's very little elastic. So this is airways, the ET tube, the bronchus, and whatnot. So this is just the manifestation of hitting the resistive load when the patient is coming out. When you pressurize, when you release the flow, so it overshoots and it looks like this. There's nothing to do. This should not cause any airway harm or lung harm, to be exact. It's just an artifact. And then the last one, the second one, you can see how the pressure drops, the flow drops rapidly, and the patient is going from inspiration to expiration rapidly. The pressure is going so fast, the flow is going down so fast because the patient is changing his muscles from inspiration to expiration, that the ventilator again is trying to maintain it at a level which is right here. This waveform should look like that. It should be a square like that. Sorry, like this. And now the patient is exhaling, and now there's an overshoot so all of this is overshoot. So it's again an artifact from the ventilator that cannot compensate fast enough. So these two ears for a bat are just plain artifact. And actually, you talked about PMOS as the patient was exhaling expiratory work, and you can see how the pressure moves actually up because the patient is exhaling, actively exhaling as he switched, and that's why the pressure, instead of being at the level of the PEEP, it goes higher during that period of time. So all of that is active work from the patient. You mentioned this waveform down here, Marina, and if there's a leak, I sometimes when you see this square root sign, it can be a leak, but it can also be that the patient did not exhale the same amount that he inhaled, the same amount of air that came out. So it resets, and then you can see here how much the air the patient put in, and the patient took another breath. So in a sense, auto-peeping, there's air that got trapped inside him. It's not necessarily, or there may be a leak. It could be, but it could be just that the patient didn't exhale all that had inhaled, takes another breath. This one is a smaller breath. We know that because it's a smaller I time and it's smaller here. And now he's able to exhale all of it. Actually, if you notice, it exhaled even more. This curve probably went all the way down here and now starts another breath because the patient exhaled more than had in because he had been air trapping in the last two more breaths. So that's a good observation. Questions, comments, disagreements, anger management? Righty. So really good one. This one is a good one to calm anxiety. So of people, that's just artifact. Very good. Now I have another one. This one is we're gonna pull out the next one. Sorry for the quality of the image, but I thought that it was good enough for all of you to see it. So there's a lot of information. I'm gonna activate the poll so that everybody can use that. Let's see how it's poll. New poll. Oops. So go at it. This is a good one. Whoever wants to do this one is welcome. Fellows.
I can do this one, Alice.
Thank you. Absolutely. So let's wait for the poll to come through. People are doing it in progress right now. 10 people doing it right now. A couple more minutes. Mohammed, I'm going to decline the annotate. I presume you pressed the wrong button, but if I press yes, then you can write on the slide, and then we have two people writing at the same time. Looks weird. Alrighty, 20 more seconds. 30 more seconds. Alrighty, here it goes. Right. So do you want me to read the answers from the poll first, or do you want to go at it first?
I can go at it.
All right.
Okay, so as far as tag, looking at the flow waveform, we can see that it's not really a uniform machine control, so it should be pressure controlled. Every breath seems to have the exact I time, and I don't see any color change. So I would say this is a CMV. It says PRVC, so it should be CMVA, but all the breath targets on the breaths are actually the same. So I'm going to say CMVA because I can see PRVC, but it could be CMVS as well, I think, depending. So next is load. I think it's predominant. There's some PMAS, but I don't see a whole lot of resistive loads. I would say a combination of PMAS and elastic. In terms of inspiration, I think there are breath 1 and breath 3 have PMAS, and breath 2 and breath 4 are elastic. In expiration, I think it's generally there's PMAS, there is no resistive load. Predominantly PMAS, I would say, in expiration. And in terms of trigger, so I think breath 1 and breath 2 are not like breath 2 is not breath 2. I think it's resetting, right? So I think the machine is reset. That's the gap. Trigger, I think I can see signs of zero flow. So I was thinking that this could be late trigger, but there is no patient interaction. So I would say that this is probably some early trigger. As you can see in breath 3, in the flow waveform, there is PMAS at the end, in the middle of the breath, and that kind of extends into the exhalation. So I think at first I was getting confused because you can see the zero flow, and I'm thinking, well, is the trigger coming late? But that's not the case. I think it's just basically that's where the phase shift difference between the patient's efforts and the machine efforts is. So
What is
inspiration,
it?
so early trigger. Inspiration, you can see those PMAS, you can call it work shifting, but I would say, I'm not really sure because it's really early trigger. You can see PMAS at the end of the inspiration. I would call it normal because that PV discordance is actually early trigger. Cycle, again, is this, let's say norm? I mean, so in breath 3, where the early trigger happened, the machine basically cycled before the patient was ready. Now, was that early cycle? I'm not sure on how to exactly do the taxonomy. I would perhaps call it normal because at least in breath 2 and breath 4, it's normal. In expiration, I don't think that there is work shifting. I think it's normal. The waveform that you see when it's going away from the baseline between breath 3 and breath 4 is actually the patient actively exhaling at the end of the breath, at the end of his. So yeah, I mean it's just a phase shift difference. So I don't know, I would call it perhaps actually expiratory work at the between breath 3 and breath 4 because the patient is doing some work.
Okay. So what would you do for this patient?
So the two ways I think I'm dealing with early trigger is either to reduce sedation or to reduce the respiratory rate. Basically, the patient, the the patient is being overventilated, the ventilator is breathing faster than the patient needs to do. So either wake up the patient, make the patient breathe faster, or make the ventilator slower.
Okay. Alrighty. Let's read the results from the poll. I'm gonna show this slide. What the majority of the people answered, Udi, was that this was PC-CMB-A. So they aligned with what you stated. Some thought that this was PC-CMB-S. The load, the majority felt that this was PMOS, and some thought that this was elastic, probably half and half, a little bit more towards PMOS. In terms of the trigger, majority felt this was normal. There were several that recognized this. Actually, majority recognized this as a failed or missed trigger, and a couple recognized this as early reverse trigger or early trigger, which we Inspiration, it was felt that it was normal. Half and half felt normal and work shifting. And in terms of cycle, the majority felt that this was actually there was half and half normal early cycle and normal cycle. And finally, in expiration, it was the majority felt that it was normal, although some people felt that there was some work. So great. Let's talk a little bit about it. This is a good discussion point. So and you brought some good points about it. So the tag is pressure control, CMB. All of them are triggered by the ventilator. So that makes it absolutely mandatory, all the breaths. And just by looking at the waveform, I could not know that this was adaptive. Just by looking at the ventilator waveform, it looks like pressure control on its own. But because I put here the PRVC, I know that the PRVC is an adaptive targeting, meaning that if the patient does effort, or the compliance changes up or down, the machine is going to change the inspiratory pressure to achieve the target tidal volume. Under these circumstances, that's how we know that it's an adaptive is just because we know the commercial name of the ventilator, of the mode. So what is the load? I think I always like to see this in conjunction, Uri. So when I see this one, if there's PMOS, I cannot see the load. So I would say that in breath 1 and 2, as you said, there is evidence of PMOS. So I cannot read what is the physiology. But on breath 3 and breath 4, there's no PMOS. And so this helps you realize what is actually the physiology of this patient. And you can see that it returns relatively fast. This is less than a second. This is 1 second from here to here. So in around 0.6 of a second, it's almost to baseline. So which tells me this is likely elastic. So I'm with you with that it's likely elastic. And then when I see the expiratory phase, without a doubt, you have evidence of this patient having some activity, some PMOS, but I can see this one, and you can see that it returns to baseline in essentially a second, 1.2 seconds, which is for all standards actually lowish, and so it again takes us towards an elastic component. And because both of them are moving in the same direction, that kind of confirms my suspicion. If this one looks elastic and this one looks elastic, I then say the main load that this individual is facing with his muscle breaths, this looks like PMA, like an elastic load. Now, you could argue with me that this waveform and this waveform are a little bit different, and so there may be some PMOS there, but they are very close by. Then the next one is discordance, and the trigger. This is actually a good teaching point for the whole group, because there's no patient trigger here. Then it cannot be normal. This is just because the patient is not triggering at that time. The trigger cannot. It's just by if there's no patient triggering, it cannot be normal. So But it's early because the definition of an early trigger means that there's a mandatory breath followed by evidence of patient activity, which is this PMOS. Instead of decaying nicely like this one, instead of decaying like this or like this here, all of this is evidence of PMOS because it's moving away from the baseline. So that tells me that there was activity after the machine triggered, as Udi said, and that tells you that this is a early trigger. Now, there's many reasons for early trigger. One of them is what is described in the literature as reverse trigger, which we'll talk a little bit more at the end of this. It is not a late trigger. A late trigger would look, what you would expect to see is a drop on your pressure and until the ventilator triggers. So it would be a large and wide space before the breath starts pressurizing, which is not the case. It's not a false trigger. There's no evidence of false triggering here, meaning a cardiac oscillation or secretions triggering these. And it's not a failed. And I will, so when you're thinking about a failed trigger, with absolutely, you're right. It looks like this. It looks like evidence of an inspiratory effort during exhalation. However, the way to recognize that this is not a failed trigger is, and in terms of taxonomy, the UDI, is what is the first thing that you see? And the first thing that occurred is actually the early trigger. So all the other discordances secondary to the early trigger, to the do not count. So, or you don't name them. So if you have an early trigger causing early cycle, you will only refer to the early trigger because it's expected to be some early cycle, or there could be early cycle with it. And the same for this one, it would look like a failed trigger, but in reality, this failed trigger is because there's an early cycle. So that kind of cancels the other one. So otherwise, you would be marking every single column on the taxonomy. So just for the sake of order, you choose the first one and the one that is causing it. I think inspiration is normal in this one and in this one, and there's a little bit of work shifting, but you could consider it normal. It's not major. It's just barely deforming the pressure waveform. In terms of cycle, I agree completely with you. It's normal cycle, and this one would be early, but as we said, we were not going to call it early just because it's an early trigger that is causing it. And finally, in expiration, it's normal. There's a little bit of expiratory work, but it's not expiratory work. The patient is not pushing to exhale. Actually, this is a nice waveform to see because you can imagine, I'm going to paint it, that this is how it would look, the flow waveform if there was no PMOS. So this is all PMOS inspiratory effort moving towards the baseline, and that's how it would have looked if the patient was relaxed. And you can see how this one and this one look somewhat alike, with obviously the flow change because there was effort. So this evidence, so how would we treat it? There's no randomized trial that is answering this question right now. And the common practice that we're having is we know that this is a manifestation of sedation. We see that in patients that are deeply sedated or coming out of it. We see it when we have the respiratory rate very high and sometimes just dropping the rate, it takes it away, the entrainment that was occurring. In some patients, it never goes away. I mean, you can stop it and then there's no reverse trigger. So meaning that the original thought that I had when they described reverse trigger, and we have described that in a couple of patients, is that the mechanical breath activates something on the diaphragm and then the diaphragm contracts. And so if you take out the mechanical ventilation breath and there's no activity, there would be no rate. So that would be one of the mechanisms in which the mechanical breath triggers a muscle breath. There's others in which there's actually entrainment of the respiratory rate. So you have the patient's respiratory rate and the ventilator rate a little bit offset. And that causes that when you drop the rate, then all the breaths are triggered by the patient. So we're learning more about this. I would be interested to see if the team, the people that are online, how they deal with this and what they think about that, if there's any comments. And don't be shy. This is new for all of us, or newish in general, and we're learning more. We see it now everywhere. Is anybody deals with it in a different way? Decreasing sedation, decreasing respiratory rate. Yeah, so when all else fails, paralyzed. Yes, happy face. The other thing that we sometimes do is if I have a patient that we don't want to paralyze, and we cannot drop the respiratory rate down because they're acidotic, and we are waiting for the sedation to go down. So you're in that gray area. One of the things that we do exactly, Fox, is we use pressure control mode, and we may prolong the eye time to hide so that the patient does not double trigger and doesn't get double or breath stacking with this. And so that's one of the strategies in which prolonging the eye time, so creating a late cycle, may help you overcome the double triggering on this group of patients. Yes, absolutely. So those are all strategies. So decrease sedation, decrease respiratory rate, increase your eye time, use pressure control, and paralysis when nothing else matters. And so Dilip, who's one of our experts on non-invasive ventilation, comments that it happens in awake sleeping patients. So in awake sleeping patients, and then
non-sedated. I meant non-sedated sleeping patients.
All righty. Yes, just talking about the perfect segue for this is that we're still learning about this interaction, and that's why we stay away from the statement of reverse triggering, just because I think that there's different presentations on how it happens. Actually, as very nice publications have put it, the early trigger can occur early on the breath. So here it can occur late on the breath here, or it can actually occur early on expiration on this group of patients. So there's different. I don't think that we have this one set up at this time. Absolutely. All righty. This one is a gift from Udi, and actually, Udi sent it to me for a different reason that I'm presenting today. I have it here for you all to read, and actually I put the whole screen because I thought that would be a good idea. Anybody wants to read this one? Come on, fellows. Have no fear.
I can try someone.
All right, Aman. This is for you. Let me. Let me run the poll as you're doing this one, and so we'll go from there. Okay. Here, open poll. Here goes. And if your head hurts, it's fault of Udi. This one is actually like a really cool one. I wish Rob was here. So go at it. Have no fear. The poll is anonymous. Challenge yourself. Put in what you feel. job. Okay, I'm gonna close the poll in 30 seconds. All right. Aman, poll first or poll later?
Poll first.
Poll first. All right. So Amanda asked to have his friends help. So let's see what it came out to. So the mode most likely to be chosen today was volume control. 8 of you chose volume control. There were others that chose VC-IMB DD, intermittent and mandatory ventilation with dual targeting, or PC-IMB SS. Those were the two that got chosen. The load was in general felt to be elastic, with some people feeling that there was PMOS. The trigger was failed to be failed, but it was divided between two groups of people. Early, half of them, and failed trigger, half of them. Then we had inspiration was felt to be normal in the majority of the cases, and the cycle was felt to be normal too. And that's all I have for you. Alrighty, let's see, Aman. All yours, baby.
Okay. All right. So the tag would be VCCMVS. I think the flow is pretty tightly controlled. It's a decelerating ramp waveform, and we have a set tidal volume. So the load, I'm gonna try to look at, so for inspiration, like the very first breath for the most part is passive. So I can see it's a decelerating ramp, and towards the end that pressure is a little bit higher. So I'm gonna say elastic predominant, and during expiration, I think after the second breath, the expiration is pretty passive and kind of is less than a second or almost a second, so it's still elastic predominantly. So the discordance, it's a bit confusing. I'm trying to make out. So I think I'll try to kind of speak out my thoughts. What's going on is, so the first breath is obviously machine triggered. It's for almost all the whole breath is passive. I think what's happening towards the very end of the breath during inspiration is this PMOS, and that's causing I don't know if the PMOS is during inspiration, but almost towards the end, that technically that would be a double trigger. But you can see the pressure waveform drops below the baseline, and that's PMOS, and that causes a second breath. And then during the second breath, the pressure waveform is deformed, so there's clear evidence of PMOS during the second breath. And the I time is cut short because I think this is then the vent is pressure cycling the breath, because the pressure alarm is set around the same level as where the peak pressure is, so that the breath is cut short. And this is the same pattern, similar patterns being repeated on the second towards the right side of the screen. It's a machine triggered breath, and in this case, even I think the breath itself is passive, but then there's again pressure cycling because the peak pressure limit is reached. But then you see it's almost cut off in the end, but you see there's another breath right after that breath, and you can see the pressure waveform dip. So I think that again, same patterns being repeated. There's some PMOS after the mandatory breath. So kind of putting it all together, the trigger I would say is an early trigger based on this pattern. And inspiration is normal, is minimal. I don't see much, I mean, during the second breath, I guess if you want to call it this, some work shifting, but nothing. So cycle, I mean, I guess in your most recent taxonomy, you label this as false cycle because, you're having pressure cycling. This is like a safety feature. I think that's the term we use. I may be wrong. But during expiration, there's no work. So I think it's a similar, I mean, depends on the situation, but if this is again a similar kind of a patient as the last one, this may be like a deeply sedated patient. So there's two things that's kind of aberrancy here. Is this may be like a reverse trigger pattern like the last case, and the extra idiosyncrasy in this case is that the pressure alarm is set around this, about this level as what the peak pressure is in this patient. So those two have to be adjusted. But otherwise, the discussion would be the same as the last case.
Yeah. Let me see what people put out.
Wow, this is interesting.
It
Just
is
have a
like
quick
not-
comment.
Huh?
Yeah, I just have a comment. You know, the first breath, the flow max is only hitting like 50. It's not getting to 65, right? It should get to 65 and then decelerate. So I think the first breath is patient trigger with a lot of PMAS. But I'm not able to figure that out. That's what caught my eye. And I think the second breath is a mandatory breath. The first one seems to be the assisted breath. That was, and it didn't truncate because the patient's PMAS was actually pushing the peak down and allowed the breath to proceed to completion. Whereas the second one is fully mandatory. There's no PMAS pulling the pressure down and then hitting the alarm. Just curious if I'm right, because this is so weird.
Yeah.
That is interesting. I would say that, I mean, independent, irrespective of patient effort, the flow should be delivered as it's set. So that is indeed quite interesting. I don't know why it's less than 60.
Yep. So I thought that we had been, so it should have been at the same height, right? 65 liters per minute, as in the one over here. I mean, if you see you have it 65, and this one is lower than 65 if you follow the flow waveform. The peak flow should have been much higher. So I really had, I actually, Udi sent this to me because he was sharing how he had been dealing with this early trigger case. And I saw this one and it made me pause for a second because there was, as you have noted, the eye time looks shorter. And so let's talk a little bit about it. So I that's why I put the whole screen on this one, because I thought that you needed all the information, and you would, if not, you will not trust what I was posting at this time. So the first one is, we agree that this is volume control. This ventilator behaves as a volume controller when we give this. It's CMV and it's S. There's no question about it. This doesn't have a hidden dual targeting or anything like that. And we have tested this one. I agree completely with you, Aman, in terms of the load. What I can say about the load, at least on this one, is coming from this waveform over here, going back to baseline relatively fast. I think that this is a ventilator that doesn't change the color of the waveform. On this one, it just changes an A and an S. So A means that the C means that it's a mandatory breath. A means that it was a breath triggered by the patient. I don't see that change or anything else. I don't see the change, but I do agree with you that there seems to be a drop in the pressure below baseline here. So I would be with you with that one. And so I think that this is early trigger, as all of you pointed out. At least these two have that characteristic in which it starts pressurizing. It seems to be an elastic load, and it keeps going up, and then it cycles off. So actually, I kept thinking about this one, because in this one I would say it's an early cycle, and this one it may be an early cycle, or early trigger, and this one an early cycle because the breath was cycled by the pressure limit. So that's why the eye time is so short in this group of breaths. Now, I also thought, and I wanted to hear from Udi, if he sabotaged me a little bit and he did the change on the ventilator settings and he was on pressure control or another setting, changed it, and then the next breath was the next setting, and we're seeing two different settings here of the ventilator, because I cannot explain the differences in peak flow between them. So we did, just to address, Anudi, you're going to have to give us if there was sabotage there. You tell me here the false statement, and actually what we did, Aman, in the final paper that we put out, we eliminated false cycle because it was a cause of early cycle. So when you hit the pressure, as you noted here, the early cycle happens because it hit the pressure, the peak pressure, and that's one of the causes of early cycle. So we thought that it was just too cumbersome to keep it there. And then the failed cycle, which was another one that we had, is a cause of late cycle. So it's when the ventilator or the non-invasive doesn't detect the end of the PMOS. So Udi, can you tell us if you were playing with the ventilator while this was being recorded and then took the picture, or what's happening here?
No, I did no sabotage of wireless. I didn't really make any changes in the middle.
So this just occurred by itself. You didn't change from pressure control to volume control.
No, I mean I was making changes, but not between those two. There were, I mean, we kept on a mode, and this is what happened, and then I took the picture.
That's interesting. So now I have to replicate this on the simulator to try to figure out why the flow is not being well controlled. It may be that it's not controlling the flow, that we overcame it, but it doesn't make sense to me. So if I would read this, it's just similar to what you read, early trigger with some slight work shifting, actually no work shifting, with an early cycle due to pressure alarming, and that's it. That's how I would read it. Now, Udi did drop the rate on this patient, and when you drop the rate, did the double the early cycle go, the early trigger go away? Or not, Udi?
Yeah, I mean, when we dropped the rate to around 9, the early trigger went away, but the patient there was a lot of PMAS to the point of excessive work shifting, and which, the pressure waveform went down to almost baseline. And at that time, so, we at the bedside were like, we can't allow there was so much PMAS. And we then actually, what we did was, then we actually paralyzed the patient, which in hindsight may or may not have been the right thing to do. So, yeah.
Well, sometimes when you don't know what to do, you go the paralysis route to try to understand it. Go ahead.
So, Eduardo, where would you mark the beginning of PMAS on the first 2 breaths?
On this one?
Yeah, on the first 2 breath, on the first breath? No, the one before that.
This one, I don't see any effort.
Yeah, that's what I'm curious about. See, look at the peak expiratory flow right after the first breath, and expiratory flow on the third breath.
This one
The
and this
third
one?
breath, yeah, that peak expiratory flow and then the third peak expiratory flow are very different. Not the second one, the third one. Yeah. If you were to say that the third one has less tidal volume, you're still getting higher peak flows there as opposed to the first one with a lower tidal volume, or with a higher tidal volume. Sorry. Yeah. So I suspect there's some PMAS going on in the first breath. We're just not seeing it.
Yeah, I agree with you. I think that's why this is different. I mean, there's more volume coming out because now here trapped, so the peak, it should be higher, the peak flow. But I do agree with you that there is that there has to be PMOS over here. That's why the peak flow is not as deep as it is, and that's why.
And yeah, exactly, and that would probably explain why the first breath with the same volume didn't trigger the pressure alarm. There has to be an explanation for that.
Yeah.
Because there's got to be some PMAS hidden in the first breath.
Yeah.
So my suspicion is sometime in the middle of the first breath, PMAS has kicked in.
Yeah, he had some PMOS around this way because otherwise this should have probably looked like that and shut it off at some point.
Yep.
That's a good point. So that's why it's an early trigger. This one is an early trigger, and this one is probably an early cycle, and then followed by PMOS afterwards. So it's 2:57. I think that we learned a lot today. I learned a lot. I keep learning. Aman is saying that perhaps our PBA40s are getting too old. Well, they are getting too old. They are old by all means. They actually, this, I think they are not even servicing them out. That's why we are in process of changing fleets. Thank you, Dilip. No comment. Next. So here is again, send us your waveforms. All of you, we are learning with this. Here's the SEVA webpage. Send us what over there. It's all the connection, all the YouTube videos. And over here is the CME for our caregivers, CCF caregivers. I thank you for your time, questions, and comments. We learn a lot every single time. I cannot tell you how I look forward to this time interacting with all of you. Thank you. Have a good day.